My name is Alexis Simonetti, and I am a senior research analyst at UHF's Medicaid Institute, and I'd like to welcome us all back from break. And it's my pleasure to introduce our esteemed keynote speaker. Liz Fowler is a nationally recognized expert in federal health policy. Most recently, she served as Deputy Administrator and Director of the Innovation Center at CMS. Prior to leading the Innovation Center, she was Executive Vice President of Programs at the Commonwealth Fund and Vice President for Global Health Policy at Johnson & Johnson. As Chief Health Counsel at the Senate Finance Committee, she played a major role in the drafting and passage of the Affordable Care Act. With over 25 years of experience, Liz is truly an authority in health policy. Her full bio can be found on our website, but without further ado, Liz Fowler.
Thanks so much for the chance to be here. It is a great opportunity, and Oxiris and UHF, thank you so much. What a great set of discussions and presentations. It really does show what New York has here and what you have to offer, and also the strength of all the numbers here. And it's an honor to be part of this gathering with so many people who fought hardest for Medicaid over the years, advocates, state and local leaders, policy experts, clinicians, researchers, and community voices. I am not a native New Yorker. In fact, I grew up in Kansas, but I did work for Senator Moynihan, and I did work here in New York for the Commonwealth Fund. And I know the sort of grit that everyone here has when you talked about how hard everyone worked together during unwinding. It was really meaningful because New York is unique in your ability to make your voices heard. In Washington, we hear it very loudly. You're probably better than anyone at that. So I have full faith and confidence that you will survive all of this and continue to prosper. But today marks the 60th anniversary of Medicare Medicaid, as we discussed, signed into law by President Johnson after more than 2 decades of debate over establishing a national health insurance program. 2 programs born in the summer of 1965 in a moment of national turmoil and upheaval. And it's hard not to reflect on that symmetry because here we are 6 decades later to the very day, and again facing deep political divisions and a defining test of our values as a nation. And as we commemorate the anniversary of Medicare Medicaid, we are all feeling that sense of sorrow, torment, anger, disbelief, maybe acceptance, but maybe all of the above, at all of the recent actions and the act by Congress to approve the largest cuts to Medicaid in the history of the program. And in light of these events, and as we sort through all the implications and think about what needs to come next, I want to do 3 things in my time with you today. Reflect on what Medicaid has meant over the past 60 years to individuals, communities, and the broader health system. A lot of that's been said already. Speak honestly about the challenges we're facing today and now, although I think Amir did an excellent job of that, as well as the panels. And then maybe perhaps most importantly, offer a perspective on how we can shape a better, stronger future together. The challenge given to me by UHF was to try to end on an optimistic note. And so I will do my very best to meet that expectation. So starting with the program, we all know those statistics. The UHF report has them: 7 million in New York on Medicaid, 44% of all children, half of all births, 64% of nursing home care. Nationwide, same picture. But Medicaid is more than an insurance program or an insurance card. It's really a foundation. It is the largest payer of behavioral health services, which includes mental health and treatment for substance use disorders. It's a critical source of coverage for people living with HIV. It's the economic backbone of the health system in many communities in New York and across the country. So many hospitals, safety net clinics, and long-term care facilities depend on Medicaid to keep their doors open. And research has shown that states that expanded Medicaid actually fared better and had fewer rural hospital closings than states that did not expand. And in some cases, that was the difference between survival and shuttering of doors. When Medicare launched in 1966, the Johnson administration used its funding power to require compliance with civil rights laws. And as a result, almost overnight, over 1,000 hospitals in the South integrated their wards very quickly. Medicaid didn't necessarily lead that charge, but Medicare did. But together, these programs have also become an important tool, not just for health coverage, but for racial justice. They demonstrated that federal health policy could be an important lever for enforcing civil rights, reducing health disparities, extending dignity to those historically excluded from the health system. And in the decades since, both Medicare and Medicaid have continued to serve as platforms for advancing equity. I guess we don't say that now, but that is the fact. And that was something in the Biden administration we tried to focus on quite heavily, not only by who these programs cover, but for what they stand for. And that is the idea that access to healthcare is a right and not just a privilege. And as a platform for state innovation, Medicaid has led the way in expanding access and coverage for social drivers of health, like food, housing, and transportation. It's laid the groundwork for coverage expansion under the Affordable Care Act, helping to drive down the uninsured rate for Black, Latino, and Indigenous Americans to their lowest levels in history. And Medicaid expansion was a cornerstone of the ACA because ACA specifically sought to plug the gaps in health coverage that left so many people without coverage. In 2010, when ACA passed, and I was there working in the Senate, an estimated 18% of the US population lacked health insurance. Thanks to the ACA and thanks to Medicaid, through the expansion in the marketplace plans, the uninsured rate dropped to 8.2% in 2024, and that's even after the unwinding. Quite an accomplishment. Those of us who worked on drafting the ACA intentionally sought to build on our current healthcare system, as complicated and imperfect as it is, and still is, to get as close to universal coverage as possible. But I think that begs the question of why Medicaid left so many gaps in the first place. And as we think about Medicaid's 60th anniversary and reflect on the legislation that just passed, it's worth remembering that the program was a compromise, carefully crafted to survive the politics of the time. In the 1940s and 50s, when most European nations were establishing national health programs, multiple efforts in the US were made to enact universal health care, and we failed. Socialized medicine was a political non-starter. But by the 1960s, momentum had built for at least some form of coverage, and policymakers began to look for a path forward that could attract bipartisan support. And that path became Medicare and Medicaid. And the architects of this compromise made strategic choices to build support among a coalition of lawmakers. Those working on the new programs didn't try to cover everyone, and instead they focused the program on the most vulnerable and sympathetic groups: low-income children, pregnant women, people with disabilities, older adults. These were the populations that legislators believed the public could support, and their colleagues would be most willing to support. At the time, Wilbur Cohen, who was Secretary of Department of Health, Education, and Welfare, as it was known at the time, helped lay the groundwork for this compromise. He worked with Congress to build a structural tie to existing welfare programs and disability programs. It was deliberately incremental, but also foundational. Congresswoman Wilbur Mills, Democrat from Arkansas and chair of the Ways and Means Committee, helped shepherd the legislation with careful attention to state autonomy and fiscal sustainability. Even the structure of Medicaid as a voluntary federal-state partnership was a product of that compromise because it gave states flexibility to participate on their own terms. And to that end, most states jumped in immediately. Arizona was the last state to adopt Medicaid in 1982, 2 decades after the law was enacted. Over time, we've expanded the program incrementally, as we seem to do as a country. I loved the history lesson. We all saw the charts with the milestones and the expansions. I hearken back to some of these expansions by referring to one of my favorite health policy quotes to illustrate a point that was made by former CMS Administrator Tom Scully, who served in that role under the first president, George Bush. He was talking about Henry Waxman. Henry Waxman was chair of the Energy and Commerce Committee during the drafting and passage of the ACA, but he was also the author of a lot of the expansions in the interim. And the quote I love is when Tom Scully, he was describing Henry Waxman, and he said 50% of the social safety net was created by Henry Waxman when no one was looking. That's because he would look for every opportunity to make progress on expanding Medicaid. For children, pregnant women, low-income seniors, he just kept chipping away. You've done the same at the state level. You were the first to expand CHIP. You were the first to adopt CHIP. I expect that you'll be able to do the same in meeting this current crisis. But what we see now is one of the pillars of the American health system really started out as this painstakingly negotiated political and policy experiment. And it worked at the time by choosing progress over paralysis. And it's continued to serve as that foundation from the Waxman efforts to CHIP, which really rose out of the failed effort at national health reform under Clinton, and then on down through the ACA, which filled many of the remaining gaps. And I think these lessons matter now because in spite of Medicaid's record of tremendous success, we find ourselves at an important crossroads. We all know what was in the reconciliation bill. I've decided to call it OB3. I agree, I'm not going to say the word beautiful. HR1 works too, but OB3, as some are coming to call it. And other speakers have addressed the crisis that we're facing. So I don't think we need to go into much detail about the $1 trillion that we're facing in cuts over the next decade that are truly unprecedented in scale. 10 million Americans stand to lose Medicaid, 1.5 million stand to lose coverage in New York alone. The top line numbers have been filled in by the headlines, but of course the real story are all the people behind all the programs, and many of the questions have gotten at some of these numbers, talking about the young adults or the people with disabilities, a lot of the immigrants who won't be able to have access to the care that they've been used to and they become accustomed to. And then, of course, the countless number of people who are going to be caught in administrative red tape who will lose coverage that they're actually entitled to. This is not a side effect of the legislation. It is an intended outcome. Speaking out on the passage of the legislation, former Treasury Secretary Larry Summers remarked that giving $1 million on average to the richest 1 in 1,000 families and paying for it by denying healthcare and basic social services is grotesque. It's by far the biggest rollback of the social safety net in our history, and he concluded by saying, "I'm ashamed for our country." Those of us who've spent a career focused on expanding coverage and access and reducing health disparities, for all of us and for all of you in the room, that feeling is really personal. We worked hard to make progress, to reduce the number of uninsured, to expand Medicaid, to envision a health system that looked beyond medical care to social determinants and drivers of health as a way to improve health outcomes and overall health. I know a lot of you in the room feel this way. The achievements over the last 15 years, from the passage of the ACA to its implementation and fruition, was really a shared victory. And so this is really a crushing blow. It is essentially a repeal of Obamacare, but with a different label and without the replace part. And not only that, it was based on more cleverly crafted policies and a set of arguments and talking points that really obfuscated the actual impact. And it was also unexpected. So those of us who've worked in Washington for a really long time, who are veterans of fights over federal legislation, were really surprised, taken aback, actually. I have never seen legislation that drummed up so much opposition, and yet lawmakers seemed not to care what their constituents were saying or screaming or pleading. But all those cuts didn't go unchallenged. Tens of thousands of people wrote letters, made calls, visited Capitol Hill, went to district offices, town halls were packed, advocacy groups mobilized their networks, told their stories. And so thanks to all of you for those efforts. It might not have stopped the bill, but it showed the full force of the movement. But why weren't these efforts successful? How in the world did the Senate bill come out worse than the House bill? Those of us who were talking in Washington figured that whatever the House passed, the Senate would cut it in half, maybe less. At most, we'd end up with $200 billion in cuts. That didn't happen at all. they got bigger, of course. And I think it comes down to cleverly crafted policy and even better marketing. And again, those arguments really hid the true impact of this legislation. And perhaps that, and no one knows what to believe anymore. As Senator Moynihan once said, everyone is entitled to their own opinion, but not their own facts. And unfortunately, in today's policy debates, everyone seems just to have as many facts as opinions. And so maybe that quote doesn't quite fit anymore. I've heard several arguments in favor of the cuts or in defense of the cuts. And maybe there's new versions or new narratives, but these ones seem to be recurring. First of all, that the program is rife with waste, fraud, and abuse, that the Biden administration prioritized maximizing enrollment in Medicaid and ACA exchanges regardless of eligibility, and expanded, quote unquote, legalized money laundering through financing schemes and state-directed payments. You also hear the argument that spending has grown beyond expectations or projections. CBO, they say, estimated that the Medicaid and ACA exchanges would grow by 25% during the last administration, and projections would alone grew 1.3 trillion relative to estimates in 2021. And state-directed payments increased from 26 billion to 110 billion just in the last administration. The third argument is that the cuts really aren't that bad, and spending is still growing. The Medicaid spending baseline is growing, and so the cut is actually a reduction in growth. The fourth argument is the one that I keep coming back to, and that's the one that seems most profound as we think about today, and that is that the program needed to return to its roots and focus on the most deserving. Able-bodied adults, it's claimed, now make up 40% of the program, and state-directed payments have eroded that federal state-based balance that was foundational to Medicaid's creation. I've heard quotes and read quotes. Medicaid was never intended to be a welfare trap for able-bodied adults in the prime of their lives. These work requirements will help get programs back on track and refocused on helping the most vulnerable. I find all of this reasoning, this idea of focusing on the most deserving and weeding out those who are not working, really perplexing. The question of who is deserving of healthcare today in 2025 is much more complex and nuanced than it was back in 1965, 60 years ago, when Medicaid was created. When Medicaid was enacted, most people worked full-time. They had one job. My dad had a job his entire life. It was the same job. And employers were more likely to offer health benefits that were stable and predictable and didn't have a $2,000 deductible. Families stayed in one place. Healthcare was largely delivered in hospitals and doctors' offices, and it was mostly reactive and not preventive. Today, we live in a profoundly different world. For example, how many in this room have a defined benefit health plan or pension plan? Millions now work in the gig economy as a contractor in part-time jobs without benefits. Career trajectories are nonlinear. People change jobs, move cities, navigate periods of unemployment. Precisely the modern realities that the ACA sought to address. And since 1965, we've come to understand more clearly than ever that one's health is shaped not just by medical care, but by the conditions in which they live. Access to affordable housing, healthy food, transportation, education, and community. The notion that healthcare coverage should be tied to employment is anachronistic. And to that, recent policies and policy debates have continued to blur the line between health coverage and employment status. For example, previous bipartisan bills to eliminate tax breaks for employer health benefits and give a tax credit for people to buy coverage on their own. Or the proposal that's now codified in OB3 that makes it easier for employers to give their employees a subsidy to buy marketplace coverage. So the Medicaid policies in OB3 strike at the heart of a question we've been trying to answer as a country for several decades, and that is whether healthcare is a right or a privilege that you have to earn. And if it's a privilege, who gets to decide whether you've earned that privilege? ACA made important progress towards universal coverage by expanding Medicaid beyond a categorical approach and filled in the gaps with marketplace, exchange, and Medicaid coverage. And of course, OB3 sought to reverse those gains and take us back to almost a pre-ACA world. By making work requirements a mandate for Medicaid coverage in all states across the board, it answers the questions of who's going to decide whether you've earned that privilege. Congress and states to some degree with some flexibility, but not much. So putting OB3 in this context, this is just really the lightest salvo in a long battle. And the fight's not over for universal coverage. It's just time to regroup, reorganize, and prepare for the next round. So what can or should we be doing? How can like-minded people who believe healthcare is a right and who believe universal coverage should be available and affordable for all prepare for the next battle? I like to think of this work in three categories. The first is preparing for implementation of OB3 and pressing for flexibility wherever possible and where it makes sense. And we had a whole discussion with many panels on all of the jobs that are coming up and all the guidance that is to be written. Those cross-agency and department implementation teams and governance structures that are needed to carry out the new work requirements and the differential eligibility redeterminations, the system builds. I'm not someone who's worked at state government, but I just can't imagine the job ahead that they have and that they're facing. All the work requirements, all the other policies in OB3, modeling the financial impact, identifying opportunities for mitigation, looking for opportunities for exceptions, implementation delays where it's specifically allowed. In terms of work requirements, working with other states and CMS on the exceptions. For example, how should disabling mental disorder, SUD, or serious or complex medical condition be defined? How much latitude will states have to make these determinations? Developing a communication strategy, working with community groups and key partners to make sure Medicaid beneficiaries understand the changes and can meet new expectations and requirements. Some states might conclude that it's easier and less costly to unwind their Medicaid expansions than to deal with the cost and bureaucratic hassles of administrating these work rules. The authors of OB3 weren't trying to make the program work better. They were trying to make it more difficult to get and keep health coverage. And that's a bonus if states rethink and roll back their Medicaid expansion. Don't give them that victory. I know New York won't, but some states might. I think it's also worth noting that part of the challenge is also going back to Congress and trying to explain the actual impact. Had several conversations with you. You've talked to your legislators, and they're all saying, oh, I didn't realize that was in the bill. Oh, it does that? How many people are going to lose coverage? That's incredible. Talk about not reading the bill before you voted for it. But this isn't the first time it's happened. I want to point out, I came to the Hill in the late 1990s, right after the Balanced Budget Act of 1997 had passed. And the next three bills I worked on were give back bills. They were called give back bills because Congress realized they had gone too far. And once they started realizing the impact, they started repealing all of the provisions that they had just enacted literally the year before. And the ACA, as much as it did for coverage expansion, and we tried so hard to pay for that legislation. Everyone talks about reducing the deficit. We paid for that bill and it reduced the deficit, but no one likes the pay-fors. So all of those were repealed. The Cadillac tax, the health insurance tax, the device tax. I think there's a lot of opportunity to go back and keep pushing all those tens of thousands of letters, all those town hall meetings, all those discussions. It's all worthwhile. Keep going. Once people really realize the impact, I think there is a chance that they rethink implementation, rethink the provisions, rethink the cuts. I think the second area to consider is to consider every platform for innovation. Medicaid has always been an important platform for state innovation. From managed long-term services and supports, home and community-based care, value-based maternity care, Section 1115 waivers, state plan amendments, CMMI models, those are smaller in scope and reach, but also provide an opportunity for creativity and innovation. And New York has really led the way in a lot of that innovation. For dual eligibles, building momentum for integrated person-centered models that coordinate Medicare and Medicaid, states have made strides to modernize managed care procurement, tying contracts to community engagement, health equity and outcomes. Medicaid is also an emerging leader for digital equity and data-driven policy. and increasing investment and partnership with community-based organizations. Whether it be innovation through managed care, spas, 1115 waivers, each of these provide a pathway to think about the path forward and innovation and to keep that innovation going. Now more than ever, states need to continue to be those engines for innovation and identify, develop, and implement new strategies to improve outcomes and provide a better experience for beneficiaries, as hard as it may be and as hard as that seems right now. And the third area is reclaiming the vision. Medicaid was created out of a belief in dignity, compassion, and shared responsibility. And that belief is just as vital and important today, perhaps even more so. Healthcare is so much more expensive and so much more complex than it was in 1965. And navigating this maze of a healthcare system almost requires a PhD in health policy. Although I have to admit, I could not counsel my parents when they were trying to find a health plan. So even that's not enough. If this moment feels like a crisis, it is, but crises can become inflection points. And what we do now and how we organize and advocate and innovate will determine what the next 60 years looks like. We are not starting from scratch. And in fact, the last decade has really laid the groundwork for what's next. After the ACA, we lost the messaging war. We spent so much time getting the legislation passed and then spent minimal effort explaining, defending, defining the law and what it will mean for people. There was so much misinformation. The other side ramped up. This law will increase your mortgage. You'll lose your house. You'll lose your doctor. They're taking care away. Both sides of the aisle learned from that lesson, that ACA lesson. I've seen more articles and op-eds, blogs and posts about the value and benefits of the OB3 legislation just in the last month, more than I would have expected. You got to give credit where credit's due. They learned that lesson. They're defending that law. But I think as we think about the path forward, the response isn't about arguing what constitutes fraud or denying that there was fraud. It's really, we're at our strongest when we talk about the people impacted and the role that the program has played in saving lives and keeping people healthy and the economic security that it provides by protecting families from bankruptcy when they need medical care. And we can't lose sight of what's happened over the last several months. And we have to remember that tens of thousands of people wrote letters, made calls, and visited Capitol Hill and district offices. And so that's what I mean. We have to reclaim that vision, tell those stories for what those programs mean for all of us. Medicaid is one of the most far-reaching and consequential social programs in American history, signed into law in a period of conflict and resistance. The program is facing an enormous challenge, but we're not starting from scratch. We have a record of success to stand on. We have tools for innovation that didn't exist a decade ago, and we have the momentum of a movement that refuses to give up. If we want Medicaid to endure for another 60 years, we have to defend it, refine it, reimagine it with the same audacity that it took to bring it to life in 1965. So let's make sure that the next 60 years are even stronger than its first. Thank you.
Thank you, Liz, for those powerful words. And the reminder that this is a time to come together. And I know folks in this room are going to remain a source of unwavering advocacy moving forward. I'll be opening the floor. We'll now be opening the floor to Q&A. If you're on Zoom, go ahead and put those questions in the chat. And those are in person, we ask that you line up at the 2 microphones. I'll start us off with a Zoom question. With the likelihood of increased administrative complexity, how can states continue to pursue meaningful Medicaid innovation without overwhelming their systems or losing momentum?
You know, I've been giving that some thought, and I think part of the innovation is how to make it easier, how to think about that. Innovation could be about trying to reduce administrative complexity, and that's part of the story of innovation. So think about what they're asking you to do and think about how to make that easier. maybe it's through some strategy that I have not focused on because I am not a state health official, but I know that this team is really thoughtful and creative and thinking about the systems. And I think there's a way to think about asking for that flexibility and asking for that exception in a way that makes it easier to implement. And that's part of the story of innovation.
Okay, we're going to go to an AHEAD model question. In a shifting federal landscape, how can models like AHEAD help future-proof Medicaid innovation as these federal policy priorities change?
So it's a tough question because, so I worked on the AHEAD model, and of course, New York is part of that in a small way, not statewide. And one of the things that we tried to do was work with the states that were ready to have an agreement signed, and make sure that that was in place no matter what happened. So we did that before the election, for example, with Maryland. And I know that there's some rethinking about that agreement and some interest in opening it up. So, I will say, I didn't think that that was possible, but there's a lot of things that have been happening that I didn't think were possible. When I was sitting in my role, where I think the lawyers would have said, I don't think you can do that. You have a signed agreement. So I'm not sure how to answer that question. I mean, I think make sure you're making your voices heard. I think this administration is interested in hearing from folks. I know they are taking meetings. I know they're listening to folks when you come into their offices. And I would just encourage you to organize and figure out what you want to ask for, what specifically you want to ask for, and then make sure you're asking the right folks for it. I don't know. It's hard to see how you agree to a global budget approach in the face of so many cuts. I think that's going to affect how you calculate those benchmarks and those baselines. So I think there's a lot to be discussed, and hopefully, and it's a small part of what New York needs to do, but I know you've got your eye on it, and some of you have been thinking about it already.
So Ms. Fowler, so good to hear you talk about not only about implementation, but also about opportunities for advocacy. And so my name is Joe Presley. I'm the Vice President for Public Policy and Government Relations at Medicare. And more of a statement, but I do have a question, I promise. I think, you're right on the money when you talk about the importance of implementation and New York State looking at that. I mean, we're looking at, what is it, $750 million by the end of this fiscal year in terms of a shortfall with Medicaid. And I think also, when we look at the budget year, next year, we're going to have a real concrete plan. But I want to turn also, my boss mentioned earlier this morning about public accountability. And I think it fits really nicely in what you're raising, because I think that if I'm reading the tea leaves correctly, this current administration down on the Hill is actually wanting us to sort of put our heads in the sand and bury it like ostriches, right? And I think it is really, really important, the public accountability piece, that we have to make certain. I think you're right. There's a chance for repeal. There's a chance for even taking some of the more draconian measures off of the table. But I think that many of us, probably some of us in this room, to be honest, have been lulled into a sense of throwing our hands up, turning to the state saying, please fix it. While we know we have to do that, I think it's extremely important that we keep the fire on and keep the heat on the folks down on the Hill. So my question to you is, and I think I have some of the opportunities, but I'd love to hear from you what you think are some of those opportunities that we should. So I'm sort of old school, grew up in the HIV/AIDS community, and there were things that we did to turn the heat on, which I don't think we're doing right now. What are some things that you think we should be doing?
I mean, I think just even start by talking to the legislators. The stories that I'm hearing some of you tell over lunch, for example, going in and talking to legislators, and they say, wow, I had no idea that was in the bill. Like, they need to understand what they just voted for, the ones who voted for it. The Democrats today in both the House and Senate introduced a repeal bill to repeal all the Medicaid provisions, and they added extending the ACA marketplace subsidy. So there's legislation out there. Start rallying behind it. Make your voices heard. And I can tell you, I have worked in Congress and CMS. There is no louder voice than the New York voice, and I am not kidding about that. You know, when there was the funding for 9/11 victims and the health issues, and everyone thought that's never going to happen. And it happened. You come together at the right time and you make your voices heard. And it's a very loud voice. You have a very loud voice. And there are Republicans in Congress from New York. And I think making sure they understand exactly what they voted for and what the impact is going to be in their districts is really important. And I think telling those individual personal stories as well, and having folks be the one to tell that story, hearing from patients, hearing from mothers with kids with disabilities, like it's hard to turn down. It's hard to walk away from that and ignore. So I don't know that I have an easy answer, but it's just make sure your voice is heard.
Yeah. Here would be yours. That go across the country, we take advantage.
Absolutely.
Hi, I'm Scott Emery, Chief Strategy Officer at Healthy Alliance, one of the social care networks lead entities that was referred to earlier. A lot of my question is kind of wrapped up in some of these things. You referred to misinformation. And so as the Chief Strategy Officer, I talk a decent amount about our biggest competitor isn't another organization. It's not somebody, going off in different directions. It's really misinformation and misconception. And so as much as we can do a lot of the technical pieces around advocacy, I'm also very interested in a lot of the other pieces of that, the adaptive challenges that oftentimes are those pieces of misinformation that you referred to. So I'm curious, from your experience and some of the things that we're talking about now, might there be lessons learned from maybe opposition? How did misinformation actually kind of work its way through with some of the things you're referring to with the ACA? I think it's going to be vital. And I know for us at Healthy Alliance, I personally and others we've met with the majority of our state legislators within our 3 regions, but also just thinking about some of those bigger pictures of we could, scream until we're blue in the face, but how do we deal with the misinformation and misconception that people hear what they want to be hearing, or whatever the case might be? So any tips or tricks around that would be greatly appreciated.
I think one of the things that surprised me after the ACA passed was the different channels. This was when Twitter was coming and new ways people were getting their information that we really weren't paying attention to, new outlets, podcasts, videos, whatever. We weren't paying attention to those. But those are the outlets, like, where do people go to get their information now? It's not necessarily the New York Times. It's not the Washington Post. It's not NPR. They're getting their information from other channels. I'm not sure. I don't have young kids, so I can't tell you what those are. But
Instagram.
yeah.
X.
Yes. Where are people getting their information? Where are your kids getting their information? What are they learning? I think there's something to be said for keeping abreast of TikTok. It's unfortunate, but that's where people are learning things. That's what they're hearing. They're these podcasts. And I think, making sure that you're covering all bases, which is one of the things that we just didn't do. We barely explained the bill. Nobody knew what the ACA did. And by the way, it wasn't implemented until 2014. That gave 4 years for people to think about, what was going to happen between now and then, and they were going to lose their house and go bankrupt and lose their doctor. That was a long time. But the same thing here, there's a long tail for the implementation. There's a lot of time to tell that story before things go into effect. And I think if anyone can do it, you guys can. But I would just encourage you to make sure you're paying attention to all avenues and not just going to the traditional sources of written reports and online reports and traditional news sources, and thinking about where people really get their information.
Thank you. We have a few more questions from Zoom. How do you see OB3 affecting home and community-based services for seniors? And how will that in turn affect family caregivers?
I mean, I've got to believe that there's more opportunity to provide care in less expensive settings, in more efficient settings, in the community, keeping people out of institutions. earlier speakers talked about the role of value-based care. To the extent that you're finding better, more efficient ways of delivering services, long-term services and supports is, I think, one of those avenues. And so I think there's an opportunity to, and this is where that flexibility and that innovation comes in, is making sure that you're exploring all those opportunities for less expensive care, keeping people in their homes, keeping them in their communities.
And then our final Zoom question is from a Medicaid beneficiary. They asked, what can we do to better educate the public so that we can help people advocate for themselves and keep their care?
One thing that has surprised me is, and maybe this is also, Medicaid used to come with a stigma, and so states renamed all their programs. And so it's not Medicaid, it's not Iowa Medicaid, or, it's Hawkeye Care, and it's not, name your state, it's not called Medicaid, and people don't know they're on Medicaid. I think making sure people understand, and I've seen some of these resources, like, you are receiving this care, you may not be receiving this care if this law goes into effect. And I think that's part of that effort to explain, is also going to people where they are and telling them what kind of care they have, what the name of it is, and making sure they understand what's going to happen if the law is implemented as written.
Thank you. And one last round of applause for Liz Fowler. And just a reminder to please scan the QR code on the screen to please complete our evaluation. We appreciate your feedback, and it'll help us improve our conference for future years. And finally, I'd like to welcome back to the stage Dr. Oxiris Barbot.
Thank you, everyone. Liz, I got to say, we gave you a tough assignment and you knocked it out of the park. Thank you so much. So before we wrap up today and I share some of my closing reflections, I want to again thank our sponsors, Commonwealth Fund and Unite Us, for their ongoing support and making it possible for all of the folks online to participate free of charge, and many of our in-person participants as well. Also want to thank our other sponsors, Accenture Health, Fidelis Care, HMA, NICE-Tech, Deloitte, United Healthcare Community Plan, Equifax, Workforce Solutions, Find Help, and Upstreams. So one of the things that I was thinking about that I hope sort of helped to encompass what we tried to do today in terms of the arc of the narrative is to remind us that during dark times, it's community that gets us through. And it's creating community of like-minded individuals who can share challenges, but can also share accomplishments. And I think one of the biggest things that we can do as a community is really celebrate on this birthday the accomplishments of Medicaid over the decades in providing care, access to care for millions of people in their time of greatest need. And I really appreciate the way that Liz sort of encapsulated that as reclaiming the vision. Oftentimes, we think about celebration as somehow, it's a party, but it's reclaiming a vision is an integral part of celebrating success. And so I want to just sort of lift that up to say that in these times of doing this hard work, we need to celebrate, but celebrate as a way of reclaiming vision. So thank you for that, Liz, and really helping to encapsulate that. And the other thing that we talked about during this day was this pendulum, right? The pendulum swings to and fro. And I've been thinking a lot about that sort of visual and the fact that sometimes we think about a pendulum swinging back and forth equally, when in reality, sometimes the pendulum swings back or forward way more than it does in the opposite direction. And so in thinking about that, I think we need to think about creating opportunities to help that pendulum swing back even more. And so talking about, not only repealing this ugly act bill, but going further in reclaiming the vision. And so the other visual that I got from one of today's panel was, I think it was Robin that said, sometimes windows of opportunity open when we least expect them, and being ready to take advantage of those windows of opportunity. But what I also heard was that sometimes those windows of opportunity take too long, and we need to figure out if we go through the front door, the back door, or whether we need to break those windows of opportunity and create our own opportunities. And I think, Liz, again, you really encapsulated it perfectly and put it back on us to say, New York has been a leader in the past. You all have a role and an opportunity to play in being a leader once again, and not necessarily accepting this new potential status quo, but finding ways of taking advantage of opportunities that are created, as well as creating our own opportunities. So with that, what I want to say now is thank you all for spending this beautiful summer day with us indoors. It's hot as hell out there, so you made the right choice. But join us in continuing this celebration. We've got dessert out there because you can't have birthday celebration without some kind of dessert. And continue the networking that you've been doing for the day. Continue that, and know that we continue being comrades in arms in this ongoing fight. And we look forward to seeing you at other UHF events, but certainly next year, same time, same bat channel, we'll be here talking about the advances that we've made. So thank you all.